pathology and risks, premalignant states, diagnosis and staging, surgery and flaps, and finally, neck dissection. Starting off with Section 1, pathology and risks. Let's build that foundation. So, geography actually dictates pathology here. If you're asked about the most common site of oral cancer globally, well, the answer is always the lip. But if the scenario specifically mentions the Indian subcontinent, the answer shifts dramatically to the buccal mucosa, or the gingivobuccal sulcus. And that's a direct reflection of regional risk factors, specifically the really high prevalence of tobacco chewing in that part of the world. Zooming in on the pathology itself, the most commonly mutated gene you need to know is P53. Histologically, we're primarily talking about squamous cell carcinomas, and if you look under a microscope, you're going to see those classic, highly testable eosinophilic keratin pearls. Now, we also have to highlight a really specific variant called verrucous carcinoma, which is also known as Ackermann's tumor. It's slow-growing. It grows outwards with very minimal invasion, it's associated with HPV, and honestly, it generally has a pretty good prognosis. Finally, beyond the obvious smoking and alcohol, never forget that sharp, ill-fitting dentures are a massive mechanical risk factor. Patients get a denture, they never follow up, and that constant, repetitive trauma over years can actually trigger a malignancy. Crazy, right? We also have to wrap our heads around the concept of field cancerization. This basically explains why patients who continue to expose their mucosa to trauma or carcinogens have such a high risk of developing additional cancers later on. Because the entire oral mucosa is bathed in that carcinogen, multiple tumors can just pop up. If a second tumor appears within 6 months of the first, we call it a synchronous cancer. If it appears after 6 months, it's metachronous. And in the oral cavity, there's a staggering 15% risk of metachronous cancer. Think of a patient who holds threading string in her mouth for salon work. That constant trauma causes a tongue tumor. Even after a totally successful excision, if she goes right back to that exact same habit, that field is primed to develop another tumor months later. Moving right along to Section 2, premalignant states. We need to catch these before they turn into full-blown malignancies. Okay, this breakdown is pure gold for your exams. It literally forces you to instantly categorize premalignant conditions. Notice that erythroplakia, proliferative Werkus leukoplakia, and chronic candidiasis sit firmly in the high-risk category. Medium risk includes oral submucous fibrosis, while oral lichen planus, specifically the ulcerative type, falls into the low-risk bucket. You absolutely need to memorize these groupings because they directly dictate your clinical urgency. Now let's dive into differentiating two really common visual presentations that trip up a ton of students. Picture this. You look in the mouth and you see a white patch. Is it leukoplakia or is it candidiasis? Well, the defining clinical test is simply whether that white patch can be rubbed off or not. Leukoplakia is a white patch that just cannot be characterized by any other condition, and crucially, it absolutely cannot be rubbed off. Candidiasis, on the other hand, often has an erythematous border and can be easily rubbed off. It's a simple test, but it changes everything. From these premalignant conditions, you have to be able to identify the absolute biggest threats. Speckled erythroplakia, which is a red patch mixed with white, carries the highest risk of malignant conversion out of all of them. Next up is oral submucous fibrosis. This is essentially a hypersensitivity to betel nut products that causes intense fibrous deposition, literally restricting the patient from opening their mouth. And you can't just cut those fibers because they'll grow back even worse. The mainstay treatment here is intralesional triamcinolone alone. Lastly, remember Plummer-Vinson syndrome. Seen mostly in perimenopausal women with iron deficiency anemia and post-cricoid webs, this syndrome massively increases the risk for squamous cell carcinomas of the esophagus and the hypopharynx. Section 3. Diagnosis and staging. Now that we know the precursors, how do we confirm it? Let's map out your exact clinical workflow. When you see a suspicious ulcer, you must do an incisional biopsy, and you always take it from the edge or do a wedge biopsy, never from the center. Why? Because the center is just dead, necrotic tissue. It's going to give you zero answers. If the pathologist tells you the sample is inconclusive, it's usually due to a superadded infection. So your next move is 7 days of antibiotics, then repeat that biopsy. Once it's confirmed, you stage the patient using a contrast-enhanced CT of the paranasal sinuses, the neck, and the thorax to see exactly where this thing has spread. Now, the 8th AJCC classification really updated the staging criteria to reflect what actually impacts patient survival. You can't no longer just measure the surface size of a tumor. Depth of invasion, or DOI, is now a totally independent prognostic factor for the T stage.
Similarly, for the lymph nodes, extrayodal extension, or ENE, is a massive independent factor. Listen, if a tumor has broken out of the lymph node capsule and fixed itself to the skin, it automatically bumps the patient up to an N3B disease, regardless of how small the actual node is.
Pay special attention here to the distinction between T4A and T4B tumors. T4A means adjacent structures are involved, but they are resectable, like the mandible, for example. T4B, however, means the tumor has invaded structures we generally cannot resect safely, like the pterygoid muscles, the skull base, or the carotid vessels. Also make a mental note of tumors with a really high propensity for bilateral lymph node involvement. We're talking about tumors that sit in the midline, like the tip of the tongue, the soft palate, or lip cancers that cross that midline. Finally, if oral cancer metastasizes via the bloodstream, the lungs are by far the most common destination. All right, Section 4, Surgery and Flaps. Let's hit the operating room. Have you ever heard of the commando procedure? This defines one of the most intense head and neck operations you will ever scrub in for. It combines 3 massive steps: a wide local excision of the primary tumor, a full neck dissection to clear out the lymph nodes, and a mandibulectomy to remove any involved bone. It's appropriately named, too, because it requires immense stamina from the surgical team, often lasting 7 to 8 grueling hours in the OR.
Depending on the depth of the tumor invasion, you've got to select the appropriate mandibulectomy to ensure an R0 resection, which nowadays means securing a more conservative 0.5 centimeter margin. A segmental mandibulectomy removes a full thickness block of bone. A hemimandibulectomy is exactly what it sounds like, removing half the jaw. But if the tumor is only superficially involving the inner bone table, you can actually perform a marginal mandibulectomy, which means you shave away the inner table while leaving that structural outer table totally intact.
Okay, so once the tumor is gone, how do we fix the defect? We have 2 main reconstructive options here. First is the PMMC flap, the pectoralis major myocutaneous flap. This is the absolute reliable workhorse for head and neck surgeons based on the thoracoacromial vessels. On the other hand, when you need to reconstruct bone, specifically in a dentulous mandible, the free fibular flap, which is based on the peroneal vessels, is absolutely your top choice. And finally, Section 5, Neck Dissection and Complications. You absolutely have to know your neck geography. You need to know exactly where levels 1 through 6 sit relative to the bony landmarks and muscles. Level 1 encompasses the submental and submandibular triangles. Levels 2, 3, and 4 run down the anterior triangle along the upper, middle, and lower thirds of the sternocleidomastoid muscle. Level 5 covers the entire posterior triangle. And level 6 is the central compartment, right over the trachea, which are sometimes referred to as the Delphian nodes. Historically, the classic radical neck dissection was highly morbid. Surgeons would just remove node levels 1 through 5, plus the internal jugular vein, the spinal accessory nerve, and the SCM muscle. As you can imagine, patients suffered severe shoulder dysfunction. But over time, evidence proved that saving these structures didn't ruin oncological outcomes. And so the modified radical neck dissection was born, which saves at least one of those 3 structures. If you manage to save all 3, it's elegantly referred to as a functional neck dissection. Now, even with these modified techniques, you're still looking at some major risks. You've got to keep your incisions at least 2 finger breadths below the angle of the mandible. Why? Because if you cut too high, you will sever the marginal mandibular nerve, also known as the ramus mandibularis. This results in a permanent drooping of the angle of the mouth, kind of similar to the iconic facial expressions of Sylvester Stallone. Furthermore, any injury to the spinal accessory nerve will leave the patient with truly debilitating shoulder dysfunction. Listen, this next part is a very sobering clinical reality. While it's definitely not the most common complication, a carotid blowout is an absolute code red emergency with a terrifyingly high mortality rate. If a neck dissection leaves the carotid artery relatively bare and an infection or a salivary fistula breaks down the overlying tissue, the artery can literally blow open. It happens incredibly fast and it is catastrophic. Let's wrap up with a massive clinical mystery. Imagine you face this exact scenario. A patient presents with an enlarged cervical lymph node, the FNAC shows squamous cell carcinoma, but when you look in their mouth, it is completely clean. You're dealing with an unknown primary. Your immediate next step here is a triple endoscopy, a nasopharyngoscopy, bronchoscopy, and esophagoscopy, to hunt down that invisible primary tumor hiding in blind spots like the tonsillar fossa or the piriform sinus. It just goes to show that in oral cancer, solving the mystery is just the beginning of the battle. So when you're faced with that invisible enemy, which blind spot will you check first? Thanks for joining me on this explainer, and keep synthesizing those clinical clues.